First of all, thank you very much for this invitation. I'm very honored to give a talk today here. Thank you very much, Shaima, for this very lovely introduction. We know Shaima already, I know Shaima already for a few years, and we were working also together in Ulm during her fellowship in Ulm, and she's a great colleague, and I really admire her enthusiasm and all work what she's doing in Egypt. So I'm very pleased to be today, and I am from the training of psychiatrist or neuropsychiatrist. So I will be shortly giving a talk about psychiatric or behavioral disturbances, or we could say mental health in Huntington disease. As you all know, the psychiatric symptoms have always been a part of HD, and I would like to highlight today the importance of approaching Huntington disease as a psychiatric, also a neuropsychiatric, or also a psychiatric aspects of Huntington disease, because those are sometimes very difficult to manage and could be even more causing more troubles as the neurological symptoms. And today we will talk about the psychiatrics and the cognitive symptoms. I just would like to highlight that already in 1860, Dr. Lund in Norway describes HD for the first time using the patient record. So I just want to show it to Sven and to Astrid that HD was also described in Norway, and also in the further works of Dr. Hoffmann in Germany, as maybe you all know from George Huntington. He also summarized the observation about the HD and described multiple psychiatric problems in his first publication, considering the psychosis, dementia, irritability, aggression. So all these symptoms have been with HD since very beginning. As was already said here by Bernard and by Michael, the main domains in HD that are covered are neurological motor symptoms, cognitive symptoms, and psychological, psychiatric, or behavior symptoms. All terms that you see here are correct. It depends what you are used to use, if you call it psychological or psychiatric symptoms or behavior symptoms. Basically, it's most important that we are all the time talking about the neuropsychiatric disorders. So we always have to consider by the therapy, neuropsychiatric, neurological, and also psychiatrical aspects of the disease. What is very important is that the psychiatric symptoms are a very common feature of HD, and often precede the onset of motor symptoms. So in the stage before, you will see in the patient the first movement disorders or first hyperkinesia. You can already notice also a decade before, prior to the onset, changes in behavior, changes in interaction with the family members. Sometimes afterwards, once the diagnosis is given, it's easier to say, okay, I have seen that this person have changed. It was somehow different. But for sure, if you are not aware of HD in your family, it can be difficult to connect these symptoms to HD. It can be very difficult with the psychiatric symptoms because they can be in very different manifestation at different stages or different points in time in the course of the disease. So it's a different symptoms that we will see in the patient. They are pre-manifest or shortly diagnosed with HD. It's a different if the patient gets a progression of the disease. So we cannot talk about one specific psychiatric phenotype. So we are rather talking about different symptoms and different manifestations. Considering the psychiatric symptoms, you can basically find all the symptoms that you know from the psychiatry training. The most common ones are the personality change, that the person is socially not active, not communicative as it used to be, that the personality changed in some way. The different disorders can come to you, like a depression, anxiety, or no interest, no enjoying life, basically. At some point, some patient could be irritable. They have problems to control the emotion and the temper. So the own behavior is difficult to control. Even repeating behavior can occur. For example, you are having conversation with the affected person, or the family members can report to you, and for you is the conversation closed, and the person can still be talking about the same topic or thinking about the same topic, also the hours and hours. And there can be a topic that are always coming back for the affected person, so it can be very demanding for the family. In some cases, apathy can start very early, but actually the apathy is always one of the symptoms in HD, and it's also very difficult to manage. Apathy can be in different kind of the intensity, and basically the affected person has no interest on the activities as it used to have, so no interest to take part on the family festivities, or if somebody was used to go to some other activities outside the home, just stop doing it. Sometimes those patients are just sitting in front of the TV and not taking part on any kind of the social life or even a life with the rest of the family. Psychosis can be also present. Sometimes with the psychosis in the younger patients or juvenile patients. Suicidal thoughts can be present, basically more in the beginning of the disease as a problem with coping with the disease, sleep disorders, and many others. I have here from 2012 a study, because there is assessment, problem behavior assessment. Unfortunately, we don't have a time to go through this assessment in HD, but maybe we can do it on the next meeting, that allows us to assess the different problem behavior issues in HD. And as you see here, they investigate the patient at the baseline and then at the follow-up. And as you see that almost 99% of patients have one or more of the psychiatric problems in the different combination. So basically, I have never seen a patient with Huntington disease without any kind of psychiatric or behavior problem. At some point, it can be something that is not causing problem. It's easy to manage, but it can be also a serious problem. So this is for your information. I have here one example of how we can assess the different problems. We could go through all the problems that was named on the previous slide, and we could discuss how this problem could be assessed. But I think that it's not possible today to go through all of them. So I just choose the irritability and aggression, or the problems to control the own emotion that we see very often in our clinical life. And it is a problem that occurs in many families. And this is something that happens due to changes in the brain. So it's always important to explain to the family that this person is not became suddenly aggressive because of any kind of reason, but it's the disease that is changing this person. And because of these changes in brain, in striatum and in frontal region and in the cortex, it happens that the person is frustrated very easily and can become explosive. And there are small things that can trigger these emotions. For example, if the person is at some point hungry or feeling some kind of pain or has some problems to communicate on needs or wishes, can happen that the person will be very aggressive. Or even if you change the daily routine, the HD patients, they like their daily routine and they like to stick to this daily routine. So every day is basically the same, but it doesn't matter for them that they don't have this kind of action. And if you change sometimes even small things that you serve the breakfast 1 hour later, or the cigarette is not given at that time as they used to have a smoke one, it can cause the aggression. So it's also important to identify the triggers that are causing the emotions, these negative emotions, and this can already help to manage them. You can discuss the feeling if it's that are behind the aggression with the person, if they are still available to reflect to this kind of communication. It's always to recommend to use simple communication with the affected person. And as I always say to my patients and families, stick to the daily routine, make your day all the time in the same way. And if there is a communication problem, or if there is the troubles, I learn my patients to count to 10 till they, it's very difficult exercise, but I always tell my patient, before you do something, try to learn to count to 10, and it's always good also for the family members. So to calm down the situation, to de-escalate the situation. For sure, there is a pharmacological therapy that you can use to help to manage the irritability. So in this way, we could assess each of the symptoms that we have discussed before. And I would just go short. If there would be questions on some other symptoms, I think that we can discuss it at the end. Sometimes I'm asked by the other doctors, how do they recognize the cognitive symptoms, that there is a cognitive problems that are coming? So what is basically affected by the cognitive symptoms? Patients lose the ability of problem solving. Even if you have, at the beginning, it's like the more complex task that they are not able to plan or organize something, or they have not this multitasking ability, and it can make difficulties to follow in the job or in the family life. At some point, there is problem with concentration, focusing on the task, to stay active, learning new information, awareness, slowness in processing thoughts, lack of flexibility, as already mentioned, and the memory. But the memory are not a typical sign of the cognitive symptoms in HD. So they are more like the executive function, as mentioned above, that are making the troubles for Huntington patients. I like this schema about the neurocognitive domains that you can have a look. Basically, all those domains are also affected by in HD, so you can have a closer look. What is also very important is social recognition, or the recognition of emotions. HD patients are not able to recognize the emotion at some point in a detail. So even if you are trying with nonverbal communication and you think that you are looking like very angry at the patient, it can be that he's not able to recognize this. So he can explain that he cannot explain, or she cannot explain your feelings. So this is very important. And if I'm explaining to the families that there is this problem, that they are not able to recognize the emotions, that you rather need to communicate your wishes very clearly in short sentences, it makes life in the families much easier. So this is something that you should communicate in its early stages of HD. I have here only a short overview about the pharmacological treatment. The pharmacological treatment, it's at some point different in different regions, and it depends on the availabilities of the different drugs, and also on the guidelines in different in different countries. So I have to admit, I'm not such aware of the guidelines in all Arabic countries. I was sometimes discussing the different cases with Shaima, so I know that all drugs that are available in Germany are also available in Egypt. And for sure, we would wish to have a monotherapy for a patient, because the monotherapy is always the best thing, so you have a better control of the medication effect. But in reality, most of our patients are on the multiple drugs, at least at 2 or 3, because you have always symptomatic therapy in HD. And on one point, you need to therapy the hyperkinesia. Sometimes it comes depression to it, and then it can be sleeping disorders. So it's always a combination. Sometimes you can have a luck and you can get away with one drug, for example, olanzapine, that can be given for the hyperkinesia, but also for psychiatric disorders. But at some point, it can be that you need 2 or 3 drugs. But basically, you should use as less drugs as it's available or needed, and in the lowest possible doses. For the depression and anxiety, we use selective serotonin reuptake inhibitors, sertraline, or even citalopram or escitalopram can be used. So I don't think it's important that I would go every single of this drug, because it will take us a lot of time. And these are the questions that we can for sure discuss. If you're using one or another one, I think this is always depending on the availability. What is also very important, always to make a combination of the pharmacological treatment and non-pharmacological treatment. So to discuss the daily instruction and this daily routine with your families and your patient. If you have a possibility of the psychotherapeutic intervention, it can be also very helpful. So from my opinion, the best is to go for a combination. Considering the antipsychotics medication.
Just, I have to remind you that the time is 20 minutes.
I have one more slide and I'm finished.
Okay.
Yeah, so this is only overview on the antipsychotics that can be used. I have my most favorite ones that I have underlined with haloperidol, olanzapine, clozapine, melphalan. But as I said here, the application is chosen depending on in what kind of application form you need your medication. If you need tablets, drops, or short-acting injections, or long-acting medication in depot formulation. So it's depending what is needed. And Svein, you'll see, if you wouldn't interrupt, I would be done in 20 minutes. So thank you